Hi Jenny, I chose to do my presentation on thyroid carcinoma. I was diagnosed about a year ago now and had 2 surgeries and had my thyroid removed and went through 1 round of radiation. Yeah, so I just thought I'd do it on this. So thyroid carcinoma in Australia in 2013, there was 2,610 reported cases of it, 75% of those female. It was a 250% increase since 1994. The risk factors include being female, having a strong family history of thyroid conditions, previous exposure to radiation, whether it be children's cancers and going through radiation then, or perhaps even living in industrial areas as a child, and other genetic conditions. The exact cause, though, is unknown. The average age of the person diagnosed with thyroid cancer was 51.3 years old, although it is the second most common cancer in the 19 to 25-year-old age group. The diagnosed rate from 2.7 to 9.2 cases per 100,000 has increased in the last 30 years, which is quite alarming. However, it is put down to medical advances and increased education around lumps in your neck. That's generally what people go to the GP for. Survival rates are now at 95% after 5 years, although the mortality rate is at 116 deaths last year, which is actually still quite alarming. Pathophysiology, so the thyroid gland sits at the front of your neck, produces T3 and T4 hormones, which increase and change your heart rate, your blood pressure, memory retention, and weight usually. There's 4 types of thyroid cancer: papillary, follicular, medullary, and anaplastic. And they're they're minimally invasive, so only 11% have distant metastasis, which is found in the lung and bone. So to be diagnosed, people will generally feel a lump in the front of their neck. They'll go to their GP, they can have a hoarse voice and fatigue. It'll get ultrasounded, they'll size it and make sure that the nodule isn't involved in the lymph and the trachea or the esophagus. They'll do some blood work and find out your TSH, T3 and T4 levels, and then you'll need a fine needle biopsy to define your treatment. Fine needle biopsy will either show that it's benign, malignant, suspicious, which you'll have a partial thyroidectomy, half taken out, and then the other half if it is malignant, and non-diagnostic. Treatment, so benign is generally left in situ and monitored. Malignant, you'll need surgery. They'll also take out lymphs on either side to make sure they haven't been involved. You'll need to have a lot of screening post-op, maybe even radioactive iodine like I had to. Supplementary thyroxine for life. They'll monitor your T3 and T4 levels to make sure that they're all good, and you might even need chemotherapy and radiation, although that is rare. Future research, so the increase in awareness and advancements in medical procedures and diagnosis in the last decade does contribute to the higher rates of it, but does not completely account for the rise. Some risk factors are well defined, but none are actually adequately account for a real increase, so more research needs to be done. There has been a US trial in the last couple of months that has shown that 2 drugs, which are MEK inhibitors, are highly efficient in preventing the reoccurrence of thyroid cancers, but yeah, more research needs to be done to improve survival rates. Thank you.